Good afternoon, everybody. Welcome to this case conference webinar series by the Clinical Immunology Society. Thank you for tuning in. This is actually going to be our last case conference for this academic year, and we return again in September of 2018. Please feel free to let us know if you have any cases that you would like to present. This is a great opportunity for you to discuss great cases, add some more presentation to your CV, and add an additional banner to your badge in the next CIS meeting. Today we have a very exciting case. Will be presented by Dr. Jenny Miller, who is our fellow at Texas Children's Hospital in Houston, Texas. And Dr. Jen Leiding is joining us as the senior mentor. She is an associate professor at the University of South Florida. I would like to remind everybody that we would like to have this to be an interactive webinar. So there is the attendee chat button on the top left corner of your screen. Just click on it and type in your question, and we'll try to go over all the questions. We only will have one case today, and at the end, we're going to do some literature review about the relevant topic. So with no further ado, Jenny, take it away.
Okay. Hi, everyone. My name is Jenny Miller, and I'm one of the first-year allergy immunology fellows at Texas Children's. I'm going to present an interesting case of chronic mucocutaneous candidiasis. So, and I'm jumping right into the initial presentation. This is a 10-year-old female who presented to the emergency room at a tertiary care center with fever, cough, respiratory distress, cachexia, with a 7-pound weight loss over the last month. She came in at 17.2 kilos, which was less than 0.01% weight for age. About a month prior to presentation, she did have an intermittent dry cough that was treated kind of as a pneumonia and asthma flare with steroid injections, oral steroids, and then an antibiotic course of amoxicillin by her pediatrician. And then 4 days prior to her presentation in the emergency room, she had a frequent wet cough with white sputum production, daily fever with a Tmax of 101, as well as significant fatigue. Going into her review of systems, the stuff listed on the slide is her positive review of systems, so if it's not listed, it was negative. She had significant fatigue, as I stated, fever with a Tmax of 101, as well as an unexpected weight change. She is small for size, but did have a 7-pound weight loss over the month prior to coming in. And she had a significant change in her behavior with significant irritability. She does have a recent thrush, but had no active thrush on admission. She had significant cough and respiratory distress, which we'll talk about in the physical exam, as well as diarrhea and dysphagia, where she had significant difficulty swallowing, which parents are contributing partially to why she had weight loss. She also had significant skin findings with nail changes that kind of had almost like a fungal look to the nails. She also had significant alopecia on the front half of her head, where she had complete absence of hair and then significant thinning on the back half. She had sacral ulcers, which were mostly due to being unable to walk around, where she had some pressure. And then she actually had some ear lesions that had kind of crusting on the upper ear. Her initial physical exam, so she was very pale, she was very cachectic, and you'll see a growth curve later in the presentation. She had moderate respiratory distress. Her lips were dry. She had an oropharynx without Candida at the time. She did have 2 small shallow ulcers on the inner lower lip. Her eyes were normal. Her pulmonary, she had decreased breath sounds on the right side, as well as suprasternal and supraclavicular and intercostal retractions. She was not tripoding, but she clearly had significant respiratory distress. Her cardiovascular exam was overall normal. She actually had normal capillary refill and no murmurs. Her abdominal exam, she had a soft, non-tender, non-distended abdomen, normal active bowel sounds, and no hepatosplenomegaly noted. She was alert and was able to converse with you, although not very talkative. which parents said was out of the ordinary for her typical behavior. And as stated in the review system, she had significant alopecia, which we'll talk about when that started in a little bit. And then also kind of had scaling of her head as well as her fingers, her ears, and then she actually had significant clubbing on her fingers. And her vital signs, I apologize for not listing them. Her blood pressure in the ER was 108/54. Her pulse was 176, so she was profoundly tachycardic. She was afebrile at the time, this is 98.9, and her respiratory distress was 64. And as a reminder, she was 10 years old, so she was tachypnic and tachycardic. Her past medical history is where things got quite interesting, or more interesting. From the age of 5 months, she actually had candidiasis that continued throughout her entire life. It was initially treated with persistent nystatin by her pediatrician. Between the time of, and she was diagnosed at Texas Children's with that. Between 5 months and 4 years of age, she kind of was in and out of care, which you'll kind of pick up on that trend for the majority of her time. She had insurance intermittently, and so most of this was done by a pediatrician who the parents trusted and would go to. So at 4 years of age, she was still struggling with candidiasis, but pediatrician noticed significant growth delay at that time, and she was sent to an endocrinology doctor who diagnosed her with hypothyroidism and treated her with levothyroxine. Approximately 1 year later, at 5 years of age, she started having mouth ulcers, and she continued to have failure to thrive, her candidiasis, and her hypothyroidism. At this point in time, her hypothyroidism was done by her pediatrician, as parents would not reliably go back to the endocrinology doctor. At 6 years of age, she was diagnosed presumptively with growth hormone deficiency, but was again lost insurance and was unable to get an ACTH stim test. Between 6 and 9 years of age, she continued with the failure to thrive, candidiasis, hypothyroidism, and then started having chronic cough that was treated as a reactive airway disease, asthma-like picture. And then, as you can imagine, while she was on inhaled steroids, her thrush became harder to control and was treated with chlorhexidine mouthwash. At approximately about 9 to 10 years of age, 1 year prior to presenting to us, she had significant worsening in her overall clinical picture. She started forming rashes all over her body. She had alopecia with significant hair loss, and had progressive weight loss as well as failure to thrive, and her candidiasis no longer was controlled with any treatment. She was referred to the NIH by her pediatrician due to some concerns for a possible immune deficiency, and they were unable to go due to social reasons. And then so she was referred to a local tertiary care clinic, and while awaiting insurance approval to come and see the tertiary care clinic, she ended up in the emergency room with her profound tachypnea and tachycardia, and that presented in the way that I discussed previously. So she was brought into the emergency room. She had lab work sent immediately, and as their pediatrician had raised concerns about a primary immune deficiency, we were called upon arrival to the emergency room and helped with workup from the very beginning of admission. So this was her initial lab work for her CBC, liver, as well as chemistries. The very alarming things are noted in red. So as you can tell, her white blood cell count was not alarmingly high, but she did have a significant neutrophils as well as bandemia, and her lymphocytes were profoundly low. She was also very anemic with a hemoglobin of 2.4. Her liver panel was normal, and she had hyponatremia, slightly calcium of 7.5, and then her phosphorus was down to 2.5. So because of her significant respiratory distress, the decision was obviously to get her a chest x-ray, which you can see here on this slide. As I said, there was decreased breath sounds on the right side, which is directly overlying where she had noted to have a pleural effusion. And then if you look in the top right kind of upper lobe, as well as the left lower lobe, there was some concerning signs for possible blebs, as you can see here, as well as there, which I'm going to delineate further in a CT scan next. So this is her CT scan that was done. There's a couple of different images. So you can see the kind of chronic changes that she has. So obviously this was not a pneumonia that had started about a month ago. She has definitely chronic changes. She also has significant blood forms that you can see on the left side predominantly, as well as some on the right upper side. And then you can see at the bottom where she has some changes here. So an overall very alarmingly different CT scan than anticipated. After that, she obviously got Microbiology Labs, which were specifically, you can see she had a peripheral blood culture, which is positive for group A streptococcus. She had a pleural fluid that she had drained by a chest tube, which grew out gram-positive cocci. It did not speciate as she had already been on broad-spectrum antibiotics at that point, but it was from that fluid collection you could see on the chest x-ray. She had numerous stool studies that were negative for infection, and she had a bronchoscopy that actually showed pneumocystis jirovecii quantitative PCR positive. She had extensive evaluation by the infectious disease doctors here, and all other testing came back negative, all other fungal and all other concerning things. She also, obviously, when she came in, we had them get a bone marrow biopsy given her lymphopenia and our concern, as well as a GI biopsy as she had diarrhea and dysphagia, and because of her history of candidiasis. She had an overall hypercellular marrow with some increased fibrosis, otherwise no large abnormalities. And then she also had a GI biopsy, which overall showed regurgitation in the distal esophagus, gastritis, as well as duodenitis, so kind of inflammation. So at this point, we recommended an immune evaluation given her profound findings on infectious and her history. So at the first slide you can see is her lymphocyte phenotyping. She obviously was profoundly lymphopenic with an absolute lymphocyte count of 228, and this was upon presentation. Overall, her percentages were of normal range, except for her NK cells, which were slightly low at 2%. But obviously her absolute numbers were extremely low since she was much lower than she should have been. We next got a B cell panel. So the percentage you see at the top is the total percentage of B cells out of the absolute lymphocyte count. And then she obviously had low B cells. They were predominantly naive B cells, unswitched IgM, IgD positive. We obviously had them get immune globulins, but she was profoundly low at 216. She had a negative HIV, ELISA, as well as PCRs. And then we did humoral immune testing, which showed a overall not protective titers, with only 4 of the 13 covered. So at this point, she was in the PICU, obviously due to her anemia. At this point, from a respiratory standpoint, she was on CPAP. She had a chest tube and obviously had severe disease on chest CT. From a heart standpoint, I did not show this, but she had an echo that showed some aortic root dilation, but not significant enough to start any medication at this time. From a CNS standpoint, she was still cognitive and aware, but irritable. From a feeding standpoint, she was allowed to eat as her respiratory rate allowed. She also had NG feeds overall for nutrition. From an endocrine standpoint, she was negative for thyroid antibodies, but she did have uncontrolled hypothyroidism. She had also had some antibodies sent with a negative GAD as well as a negative S-actin. From an immune standpoint, you saw the labs that previously were discussed as well as the bone marrow biopsy, and she was on broad spectrum antibiotics for coverage for bacterial and for fungal. So that is overall her initial presentation, and so they asked us what our primary concerns were and what our top differential diagnosis was. So.
Yeah, Jenny, before you go on, and yes. I'm sorry if I missed it. Did you talk about the antibody or what was the cause of her anemia, or were you guys able to find that? If it was not, active GI loss of blood, was there any evidence of hemolysis or anything like that?
Right. There was no evidence of hemolysis or losses.
Okay.
She did. I think so. We could not find any other finding. There was no large areas that blood was collecting in. So it was she did have a hemoglobin of about 10 a month prior, but there was no significant GI blood losses or losses that we could find of anywhere else.
Okay.
And at this time, I think we would like to invite the attendee to put in their thoughts, questions, their differential diagnosis. As a reminder, if you click on the attendee chat in the left upper corner of your screen, you will get a box. You can type in your question and press enter. So we got one suggestion about STAT1 gain of function. STAT5 deficiency was another differential. APICID was put in on the differential diagnosis as well. APICID popped up again as a differential diagnosis. And then with history of autoimmunity, APICID was suggested as well. So did any of the audience needed any more testing to be done at this time? If you have any suggestions about any workup, feel free to kind of place in. There is a question whether WHIM is a possibility. Words with hypogammaglobulinemia, immune deficiency. What were your thoughts at the time, Jenny?
So whenever... So I did not elaborate this because I did not want to kind of taint the picture, but when she came in, the primary concern by the pediatrician was actually APICID, so that was obviously a high part of our differential. We also thought about STAT1 gain of function given the chronic mucocutaneous candidiasis as well as the hypothyroidism. And so we kind of, those were our top two differentials once she came into the ICU. And we realized she did not have any testing at all identifying if there was a specific gene.
One other differential diagnosis was brought up is IL-17 receptor deficiency. So those are all great differential. Any workup that any of the audience would suggest?
So another additional thought, and I was thinking this especially when you showed the chest imaging, is autosomal recessive, or not recessive, dominant hyper IgE syndrome, so Job syndrome. And I was curious if you guys checked an IgE or eosinophil count. I'm assuming they were normal just because you've left them off. But I specifically was thinking this as you showed this imaging just because of the blebs and the severe sort of deterioration of the pulmonary findings. And we can see, Candida or chronic mucocutaneous candidiasis, which is, I think, what you're implying this patient has by their chronic thrush and fingernail changes. That's relatively common in Job syndrome as well. So.
Right. She did not have significantly elevated eosinophils, and her IgE was in the normal range.
And Jenny, one question came about her neutrophil count. So were her neutrophil count normal?
So she had some slight left shifting. So she had about 74% segs and a 17% bandemia with a white blood cell count of about 7. So she was not profoundly high, but she was also not neutropenic at the time of initial presentation.
And one other question that was asked, doing neutrophil function, so I would assume that was like a neutrophil oxidative burst. So was this done?
I do not believe that a DHR was done on her, to be honest, which is surprising, but I do not believe she had one done.
Right. Because one of the differential was a CGD. She's a female, so probably suggesting autosomal recessive, and FKAPA B2 was suggested as well. And of course, hyper IgE, just like Jen mentioned, with nematoceles, hyper IgE syndrome was suggested. All right, I think you have a fairly reasonable list of differential diagnoses, and you've done quite an extensive workup up this time. So would you like to share what was the next step of your workup?
Sure. So kind of listing these, I don't think it's entirely have all of the suggestions that were made by the audience, but a lot of them were obviously APIS-Fed was on kind of the top, as well as STAT1 gain of function, the IL-17 pathways, STAT3, DOCK8 patients, as well as the CARD9, and ataxia telangiectasia. So kind of just some of the thoughts that overall had. So when she came in and she had this kind of presentation, and we were considering an APIS-Fed versus STAT1, being where we were at Baylor, we have the ability of doing a critical trio whole exome and are able to find out an entire exome in a matter of 14 days or so. And so we were able to order that on her because that would help us get an idea. Rather than sending specific gene testing to different places, it was actually fine for us to do this specifically. So the next slide is going to show her gene mutation that was found on whole exome. So she was found to have STAT1 gene mutation, autosomal dominant. Both parents were negative for it. So this is a de novo chain. It was found, it was chromosome 2 and exon 14. And so based off of this de novo change in the STAT1 gene, she was presumed to have STAT1 gain of function disease at that time. That's the large picture. After that, we decided to do natural killer cell studies, which you can see here. I'll have to describe the graphs a little bit because of patient confidentiality. I had to take off the legend. So in the top left corner, you have natural killer cells, spontaneous cell cytotoxicity. The blue is the control, and the red is the patient. So the bottom red line that you can see here with the clear diamonds is unstimulated, and then up here is when you have the blood is stimulated. And this is for the patient, and then here is for the control. So as you can tell, she has significantly decreased in K cell studies. Again here, this is unstimulated for the patient. This is the stimulated antibody-dependent cytotoxicity, and here is for the control. So once again, significantly different, which we have seen in a number of our other STAT1 gain-of-function patients. For her treatment overall, she obviously had multiple blood transfusions that then stabilized. Her infections were treated with antimicrobials, both bacterial and fungal. She obviously had significant lung disease treated with the antimicrobials, and because of the large blebs, she actually had required a lower lobe resection. She had diffuse and severe pleural fibrosis with pneumatoceles and lymphocytic bronchiolitis. And then her hypothyroidism has been treated with levothyroxine. And then she was actually later found to have adrenal insufficiency, which they identified, but they do not feel she needs to be on steroids on a daily basis, only as needed. And then the last thing is we obviously, most of our patients with STAT1 gain of function, we discussed starting ruxolitinib on them, which is what she had started on. She had significant improvement in her lab work. Her part of the reason her hemoglobin stabilized, we think, is largely because of ruxolitinib. Her candidiasis is much easier to control with less treatment. Her GI symptoms obviously decreased, and as you can see on the graph below, her weight has significantly improved. As you can tell, when she came in here, she was actually the size that she was when she was about 7, and so there was a pretty significant climb up in weight. We are still struggling with weight gain with her due to intake, and so she's getting a G-tube for helping with her nutrition. And her skin and hair have almost completely resolved. Her head is completely full of hair, and she has a full head of hair now. And her skin findings, the nail findings, as well as her skin findings on her ears, and all of it are now resolved. So she is much improved ruxolitinib and appropriate antimicrobial treatment. That is her story. So, are there any questions about her?
The only teaching point I would kind of bring up is great job on diagnosing her, and that's awesome. But for the team, I think, and just the attendees in general, how do you know this is a gain of function mutation in STAT1? So we get these, those of us who do this a lot are getting these reports of mutations, and what's the way that you know that this is a gain of function or even a pathogenic mutation? Did you guys Did you guys look at that, or how would you guys work that up? And maybe the audience can kind of jump in there. So the point I was trying to get at, and I don't want to belabor it so you can move on in the conversation, but is so you can do functional testing looking for hyperphosphorylation in STAT1, but I think probably the easiest way, specifically in your patient, is this is a well-described mutation. So there's many patients who have had this T385M protein change and the specific base changes that you've seen that are well published. And so, you know, the phenotype fits, you have a mutation that many other patients have had who have similar phenotypes, and so that would probably be enough to confirm the diagnosis, but you could also do functional testing if you're in a facility that can do it, looking at hyperphosphorylation. But I think that's an important point to make, that just because we're getting a genetic test, you really have to confirm what you think you're seeing or the pathogenicity of the mutation. So.
And Jen, we got a couple of questions that I thought are important. Maybe you can help elaborate on that. One question was, please explain the autoimmunity in STAT1 gain of function. And the second was, what is the mechanism of anemia in STAT1 gain of function?
So those were great questions that I wish I knew the answers to. But so I think that, you know, we know that STAT1 gain of function is a T-regopathy, and that there's issues with development and maintenance of T regulatory cells. And so that's been implicated as the cause of autoimmunity. But why the specific organ systems are affected in specific patients is not well understood. There's no obvious genotype-phenotype correlation as far as, you know, somebody getting endocrinopathy versus getting hematologic disease, et cetera. Typically, that's why I was asking about the anemia and when Jenny was presenting. You know, often I think we see autoimmune hemolytic anemia, and that's what I was actually thinking was going to be the case in this patient. And you see autoimmune destruction. You less frequently see production issues, then the last is loss, and typically the loss is in GI form. So if we have chronic enteropathy, there can be blood loss or chronic colitis or enteropathy. You can see blood loss from the GI tract, or even what we similarly see in CGD, which is poor iron absorption that can then lead to anemia. So it can be sort of a combination of those things. I think an important point in this patient too is she was septic at the time. So there was clearly some vascular changes happening. The fact that her hemoglobin was relatively normal a month preceding this, I think, would argue that she's probably not that anemic at baseline, but that she had some, inciting event that was leading to her anemia. But in general, in STAT1 gain of function, it typically fits into autoimmune hemolytic anemia or loss for the most part. So, and typically GI losses if you're going to have blood loss.
Right. And would you say the autoimmunity is antibody mediated for the most part in those patients?
It is, I would say for the most part it is, but it's not always. So we see sometimes, I think of things like antibody mediated or T-cell mediated, and the T-cell mediated is sort of hard to prove. But we see both. But I do think there is a predisposition or a preponderance of antibody mediated autoimmunity.
And Dr. Leiding, just to clarify further, it looks like her peripheral smear that was done potentially after a transfusion, and so they showed very rare schistocytes. So that may not be the best picture of what it would have looked like if we looked at it right when she came into the emergency room.
Sure. And I mean, she could have had DIC. There could have been a lot going on because she was actively septic, obviously. So I think your better workup of that is probably, well, maybe pre-ruxolitinib, but after your event, so. Okay. Oh, there's lots of other people. Oh my goodness.
So there are some questions. What was the cause of the alopecia? Was it autoimmune? And would you expect the hair to regrow? I think Jenny already mentioned that her hair regrew. The other question, do you screen for aneurysm routinely in those patients?
Do we screen for what? Say that again, Jude.
Aneurysm. This patient did have on the echo some aortic root dilation, so they are asking if you screen for aneurysms in those patients routinely.
So, Jenny, did you screen in this patient? Maybe we can answer about this patient.
So we screened with an echo, which showed the aortic root dilation, and then she is scheduled to go for an MRA to assess for brain aneurysms. And I believe she had renal testing as well that was negative.
Yeah. So in my patients, I screen for aneurysms as soon as I get the diagnosis. And how frequently to do that when it's normal, I don't know the answer to. Doing an MRI or an MRA on a small child is no small task. So I think you have to weigh the risks and the benefits of anesthesia and just the cost against how uncomfortable we are. So I would say if there's ever a change in neurologic status, that they deserve repeat imaging. But how frequently outside of that, I'm not sure what the right answer to that is. Is it yearly, every 5 years? I don't know. I will say, and Lisa and I actually had this discussion recently, Dr. Forbes and I, that I follow one small young girl who is about 2 years old, who we diagnosed purely because her mother had STAT1 gain of function. And she had an aneurysm on her very first MRA. And that was done at about 6 or 8 months of life. And so that tells me, at least in her case, that something embryologically is occurring that's leading to the development of these aneurysms. And so, is that the case in everybody? I don't know. But it's interesting, at least in that particular case, that was present so early. So it's not an easy question to answer, but I would say at least everyone needs to be screened at the time of diagnosis. And then after that, who knows, at least based on what we know now.
Great. I think we'll answer one more question, and I think the other questions will be answered as we go through the discussion and the review of Dr. Leiding and Dr. Forbes' paper. But there's a question asking, what's the mechanism of hypogammaglobulinemia and STAT1 gain of function?
Yeah, I think the majority of the time it's loss, again, GI losses. But it's also a production issue. So we tend to see the hypogam and the lymphopenia sort of go hand in hand. So it's probably a production issue and then can be compounded by loss. But the exact molecular mechanism, I don't know. I don't know that that's known yet.
Right. And there are questions about hematopoietic stem cell transplant and profound lymphopenia. And I think maybe it's a good time to go over your paper, and Jenny's going to summarize a little bit about STAT1 gain of function and talk about the collective experience nationally. So to help answer the rest of the questions.
Sure.
So I'm going to go through some of Dr. Leiding's information and slides that she actually presented, I believe, at the CIS conference, so you can kind of get an overview. First of all, is the slide is that clinical presentation of STAT1 gain of function versus STAT1 loss of function. So if you look at the picture, and this is adapted from a paper in 2012. So you can see the loss of function over here with a decrease in interferon versus the normal versus gain of function. Here you can see that you can have some changes in the interferon gamma, interferon alpha, and beta, as well as the IL-17. This picture is actually very characteristic of what our patient's fingernails looked like. And then obviously you have the thyroiditis. So you have an expanded phenotype of the gain of function. You can have kind of an IPEX-like phenotype with autoimmunity and enteropathy. You can have broad fungal susceptibility with histoplasmosis, cryptococcus, and coccidiomycosis, as well as combined immune deficiency with a lymphopenia, hypogammaglobulinemia, as well as severe viral infections, HSV, VZV, and EBV, which thankfully our patient did not have. The next is a graph from a picture from a paper in Blood of 2016 that shows in a group of about 270 patients the survival on the top in the blue without severe complications, STAT1 gain of function, versus if you have significant problems. So as you can tell, there is a significant survival difference later in life if you have severe complications versus without severe complications. And the next thing that we're going to go through is Dr. Leiding's paper discussing from the JACI recently. So this kind of graph, I apologize for the small writing, but you can do, so discuss 15 gain of function STAT1 patients who underwent stem cell transplant. From over here, you have one with primary graft failure and then died about 6 months post-transplant. You then have here that 2 that passed away before primary engraftment happened. And then you have 12 in the middle who had primary engraftment, and then a couple of different kind of outcomes for them. 2 passed away in the first 100 days. 4 had a full immune reconstitution and resolution of disease, and then 6 had secondary graft loss. 3 passed away. 1 was retransplanted with no primary engraftment, and then passed away from that. After that, another had retransplanted and had resolution, and then 1 had mixed chimerism. So of this 15, there was kind of a broad array of different outcomes for these patients that underwent hematic stem cell transplantation. This looks at the overall survival and days of post-transplant in patients, as well as the percent of graft survival that you can see here. And then here's overall, this is kind of a summary where you have 15 patients who were transplanted. Typically, these patients were transplanted. They were for severe life-saving measures, severe infections, HLH, or overwhelming autoimmunity. They had about a 40% survival after 1 year, and 9 patients passed away. And they had increased survival if they were less than 12 years of age, had non-myeloablative conditioning, and some survival advantage to the T385M. So, Dr. Leiding, do you have any other things to contribute to that part?
Sure. So, so I think this paper, tells us a lot. The first is the survival is relatively poor. Although, that being said, you have to remember these patients were all transplanted as sort of a last-ditch effort or a last resort because of such bad disease and underlying infections. And if their disease had been better controlled at the time of transplantation, perhaps survival would have been higher. The other is if transplant had been done more on a more elective basis instead of as a life-saving measure, you would expect that the survival would be higher. I think one thing we did not necessarily anticipate seeing, but then as we were mining through the data, was this high degree of secondary graft failure. And that's pretty alarming for this disease, and also gives us a little bit of pause as to the strategy of transplantation for these patients, as well as the trigger to sort of pull when to do it. And so we saw, you can see in this graph that Jenny's showing that we had 6 patients who had secondary graft loss. And in those who had graft loss, their outcomes were variable, but having the secondary graft loss was one of the stronger predictors for mortality and overall morbidity. So it was not a good thing, obviously, to have secondary graft loss. That gave us a lot of pause as to, like I said, who and when and how. There were a variety of conditioning regimens used in donor sources that were used, and at least in these small numbers, none correlated with the graft loss. So it wasn't, excuse me, it wasn't as if one type of conditioning regimen led to the graft loss, is what I'm trying to say. And so, like I said, that gave us pause. One interesting patient, when you dig into this paper a bit, who really did the best and had sort of the best transplant course, was a patient who received ruxolitinib as part of their conditioning regimen. And this was a patient out of the United Kingdom. And so when we saw that, it also made us think a bit about what could be going on mechanistically. And you have to think about this particular disease has such a strong interferon gamma signature. And some of the data you're going to show in the next few slides regarding ruxolitinib, I think, will be helpful. But when we see that, we know that because of seeing how well this patient did and knowing there's such a strong interferon gamma signature, I've started thinking about this disease as almost like HLH. And there needing to be, at least in regards to transplantation, and there needing to be some sort of conditioning regimen or specific therapies that can blunt that interferon gamma response. And I personally think that's probably why there's such a high rate of secondary graft loss, is because that interferon gamma signature has not been maintained or blunted. So the slide you're showing right now is this sort of expanded phenotype of STAT1 gain of function. And, we have, it's getting so much more complicated. We have STAT1 loss of function, we have STAT1 gain of function, we have hypomorphic mutations in STAT1, and then the gain of function phenotype is expanding upon itself as well. But most patients, I would say that I follow personally or know about, tend to fit into one of these buckets or one of these groupings as an IPEX-like phenotype, bad fungal disease, invasive fungal disease, or combined immune deficiency. And they occasionally can kind of cross borders and fall into more than one, but they tend to sort of segregate. And I would say, at least in my experience, the CID ones tend to be the ones that are the hardest to manage because they have so much infectious susceptibility on top of all the autoimmunity. So, but you will sort of see that. And these are important phenotypes to remember because these are how these patients are going to present. And you may not necessarily think right away about STAT1 when you see a patient with lymphopenia and hypogam. That might not be the highest disease on your differential diagnosis, but it should be based on this data. So this is really kind of an important slide. That's probably the only things I would add, at least about transplantation. I think the who, what, how, why, where is yet to be determined, and many of us are trying to sort that out now to give better guidance. There were a few questions that popped up, Jude. Is this a good time to answer them, or do you want?
Sure. So there is a question, is there a preferential hematopoiesis of lymphocytes carrying the mutation, i.e. if there are remaining hematopoietic stem cells after the conditioning with the mutation, are these out competing the transplant and reacting against the transplant?
I don't know how to answer that. So I don't know that there's any data supporting that. Meaning, do you need myeloablative conditioning to completely ablate them in order to prevent that from happening? I mean, that could be true of any primary immune deficiency, that there be mutated cells that are hanging out. I don't know that to be true in this particular disease.
Sure.
So I don't think that myeloablative conditioning is necessarily the answer that we're all searching for.
The other question is about the role of immunoglobulin replacement therapy in controlling infection. Jenny mentioned that this patient was hypogam, so she was on immunoglobulin. And your experience, Jen, do you place everybody on immunoglobulin replacement therapy?
I don't. I do if they have hypogam or they're lymphopenic, profoundly lymphopenic, or both. I have to say, I've not seen a lymphopenic patient with STAT1 gain of function who was not hypogam. So I don't think you see them independently. But if you have normal immunoglobulin, normal lymphocyte subsets, normal lymphocyte proliferation, normal vaccine titers, I don't put them on immunoglobulin. I don't necessarily know what the indication would be, but maybe others disagree.
One question that I postponed till later comes in about a patient who had a novel mutation and had an interferon gamma induced activated sequence, so had interferon gamma gas. And Yesim talks about the activation was detected by reporter assay that was done at Casanova's lab. This speaks to your point, Jen, that those patients have a significant interferon gamma signature, which might be maybe participating in the graft rejection. Do you do those kind of assay?
I personally don't, but they have been done. So I think that I don't know that each mutation is going to have a different interferon gamma signature. Maybe it does, and I just haven't looked. But I think in general, STAT1 gain of function has this high interferon gamma signature in the background. And I think there's some, what you just were speaking of is we know that, at least in other immune deficiencies alike, that when interferon gamma is floating around, it affects the kinetics of engraftment, whether that's primary engraftment or maintenance of the graft, etc. And I think there's some strategy, like I said, to the blunting of that response. But I don't know that it's genotype specific, that if you have, one genetic mutation, that your interferon gamma signature is higher than in others. That'd be an interesting thing to answer, but
Sure.
I don't know that to be true.
And I think Jenny has maybe two more slides to go over.
Yep. Yes. So obviously, Dr. Leiding went over went over this. So you have the interferon gamma and the cytokines receptors, and you've got the JAK1, JAK2, JAK3, and it shows JAK-inhib where you have some kind of blocking of this JAK-STAT pathway, which helps with the upregulation of the gain of function here. So this is kind of where the idea of using ruxolitinib in these patients has stemmed from. So this next slide is a paper done with Dr. Forbes and Dr. Leiding that reviewed 9 patients that used ruxolitinib as a primary treatment for the gain of function STAT1. And overall, 2 of them had resolution of their enteropathy, 2 had resolution of cytopenias and alopecia, 6 had control of their candidiasis, and then 8 of the 9 patients survived. So at this time, when we see most of our STAT1 gain of function patients here at Texas Children's Hospital, that's one of the first things we do is start putting them on ruxolitinib. So we have a handful of children here that get put on ruxolitinib, and it is helping control their disease, whether it's been enteropathies, something similar to IBD versus cytopenias. And so I believe there is building a cohort of these patients that are being able to help with the ruxolitinib, are having improvement significantly with the ruxolitinib with their disease. So our patient is one of those patients who's definitely improved while using ruxolitinib.
So I can tell you, so we are now up to 11 patients on this, and Lisa and I just resubmitted the paper about 2 weeks ago. It's been provisionally accepted, so hopefully we'll be out very soon. But in the manuscript, we have 11 STAT1 gain-of-function patients and 5 STAT3 gain-of-function patients who have received ruxolitinib. So I'm only going to concentrate on the STAT1 when we're talking, but of those 11, we had 1 death, which is included in your table, and that's patient 5. So that particular patient was, I think, probably the first patient to receive ruxolitinib with STAT1 gain-of-function and was treated at the NIH. It was a young girl with coccidiomycosis, very disseminated, I mean, literally everywhere. So she did not respond initially, but it was very terminal at the point that it was started. So it was, again, sort of a life-saving therapy in that particular context. The other patients who have received it either received it also as life-saving therapy or early on in their disease and have had remarkable success with the use of ruxolitinib. So many of them have done, like I said, remarkably well. The dosing that we used, and we go into this a lot in the manuscript, so I would encourage you guys to read it when it comes out because it's sort of a good way to determine the dose for your particular patients. But the dosing strategy that Lisa and I have used is based on what little pediatric data there is. So ruxolitinib is approved for myelofibrosis and polycythemia vera, both in adults, but it's been used for myelodysplasia a little bit in children. And so that's where the data came from, and we extrapolated from that. And mostly, I will give the majority of the credit to Dr. Forbes, have developed a dose escalation to use in these children based on body surface area. And the dose escalation is made up over about 7 to 14 days, depending on how your patient tolerates it. So we monitor complete blood counts and transaminase levels at least weekly for the first few dose escalations. And if there is problems in those laboratory values or abnormalities, then we decrease the dose accordingly. The biggest one that her and I have both seen have been thrombocytopenia, and so we've had to reduce doses because of that. And then the other monitoring that we do is we monitor for invasive viral infections, especially in those who have combined immune deficiency along with their disease phenotype, or lymphopenia, I should say, along with their disease phenotype. And the rationale for that is that these patients are already sort of at risk for invasive viral infections. We're not, completely confident that ruxolitinib is not placing them at higher risk for this. And there is some data on the use of ruxolitinib in other immune deficiency states, specifically in the autoinflammatory diseases where there has been some reports of invasive viral infections. So it might be overkill or maybe overly cautious, but that's what we currently do and recommend. We also have seen, excuse me, in our manuscript, two cases of patients two specific patients and two cases of herpes virus infections while on ruxolitinib, and both patients had herpes zoster. In one patient, they came off of, or I should say, in both patients, they came off of ruxolitinib, and then both were treated with antiviral medications, and the zoster went away. In one patient, they restarted ruxolitinib, and the zoster, they've remained herpes-free. In the second patient, the family refused to go back on ruxolitinib, and the child had return of all of their underlying manifestations related to stat-1 gain of function. So because of that, we have also recommended that patients be prophylaxed against herpes virus infections with either acyclovir or valacyclovir, just based on that data. So that's the story with ruxolitinib, and then hopefully we'll be out, like I said, pretty soon in the JACI. And then we're hoping, just sort of as future directions, to develop a prospective, especially pediatric trial for the use of this in stat-1 gain of function and other diseases like it, so that we can understand the pharmacokinetics and the appropriate dosing, especially for children.
Jen, there was one question that came up about concern of growth in patients receiving Ruxo. So did you see that? Do you see any growth impairment?
I actually see the complete opposite. So right. I have two or three patients personally, and then also in this series, who have had horrific enteropathy from stat-1 gain of function. So one of the very first patients to receive ruxolitinib, at least in my hands, is patient 3. And this patient is actually patient 1 in the transplant paper. And patient 3 here, so he was patient 1, he's the mixed chimera from the transplant paper. And over the last several years, his chimerism has continually reduced to the point that he's had almost, I can't yet call it complete, but essentially complete graft failure, and had return of disease, and had horrific enteropathy. TPN dependent, very, very bad, was stooling up to 6 liters a day. That's how bad it was. And so when we started ruxolitinib, within about 3 weeks, his enteropathy was completely gone. He was off TPN, and over the course of about 4 months, he gained 25 pounds. So this was like a remarkable drug for this particular patient. And I will say in others, that has been the case. So we've not seen stunted growth. We've actually seen catch-up growth. And that occurs not just in those who have enteropathy, but it's more profound, obviously, in those with enteropathy. But in those without enteropathy, we've also seen growth improvement. So that hasn't been a major concern for me with this drug. Anything else regarding ruxolitinib?
Maybe I'll ask a question till the attendee if they have any other thoughts. Would you now think about ruxolitinib as a bridge to transplant, or would you not consider transplant for those patients based on the data that you've published with Lisa?
I think both. So I think it's definitely a bridge to transplant if you have a good donor. So I think that's your first question, is do you have a good donor? If you do, I think it's a good bridge to transplant, and I think it also should be part of the conditioning regimen. So it needs to be well thought about and continued up until some amount of time pre-transplant. In the one patient that received it in our cohort, our transplant cohort, I believe they stopped at 9 days preceding, but that was kind of random. It wasn't necessarily like a well thought out, let's stop at 9 days ahead of time. The half-life for ruxolitinib is incredibly short. So I don't know that you have to stop it that long out. But I think that it needs to be part of the conditioning regimen. I think you get patients' disease under control and then go to transplant if you have the appropriate donor. So that's personally what I think. I think a lot of patients become resistant to transplant because they get so much better on ruxolitinib, that they tend to think, oh, I'm just going to stay on this forever. And that's obviously theoretically an option, but we don't know the long-term data of this medication. And so that's, we have to inform patients of that. So.
I would like to invite the attendee to see if they have any last thoughts or questions. Jen, do you have any final teaching points, tips for early career immunologists about STAT1 gain of function?
Yeah, I think the biggest thing is that our disease, our two main things, our disease phenotypes are changing. And so we have to change with it. We have to adapt with it, right? And so this is one of these diseases that we wouldn't even necessarily think about 5 years ago, right? You thought about it in regards to Candida, but not necessarily the lymphopenia and the anemia and the hypogam that this patient had. So kudos to the team for even sort of thinking of STAT1. And then I think the other learning point is that, when you get your, and I brought this up before, when you get your mutations, you really need to confirm it. Let's not just assume that something is a gain of function or loss of function mutation. And the easiest way to confirm it is that if somebody else has had it. So that's kind of, in this case, that happened as well. And then, once you've made your diagnosis, now you've opened a can of worms, and you really have to figure out how best to treat the patient. And I think in Jenny and Lisa Forbes' hands, this was, or the whole Texas Children's team, you guys did a great job, identified it right away and put the patient on the right treatment. So those are the good, I think, pearls to see as a budding immunologist, that obviously this seemed abnormal. You didn't need a pediatrician to necessarily tell you that, although they did. So kudos to that pediatrician. But when it looks abnormal, it probably is abnormal. And so you need to search out the gene.
Very well said.
Leave it at that.
Very well said, Jen. I think we didn't have any more questions. Jenny, that was a wonderful presentation. Jen, that was great. All the discussion. I'll let Jenny read her acknowledgements.
Yes, so I wanted to thank Dr. Leiding for helping and being the senior mentor here and stepping in where I needed some guidance. And then Dr. Forbes for the care of the patient, and Dr. Hajar, as well as the faculty here at Baylor and Texas Children's, as well as the Clinical Immunology Society, and most importantly, our sweet patient. So that's all.
Well, thank you so much, everybody, for tuning in to our final CIS webinar for this academic year. We return again in September of 2018, so please send us your cases. Again, it's a great opportunity to have great presentations just like the one we had today. And I'd like to thank you all for your attention. Have a good night. Bye-bye.
Thanks.